incidence and epidemiology, this is data mostly from the US. And in the US, the incidence is 3.2 per 100,000 population. Some other countries have reported more. So roughly the incidence is around 3 to 5 new cases per 100,000 population per year. So, in a country like Karachi, which has 2.5, with 25 million people, you can expect many thousands of GBM glioblastomas diagnosed every year, many thousands. And we are obviously not diagnosing them enough, we're not treating them enough. Um, the median age at diagnosis is 64. This is again the data from the West, but the incidence is we're now diagnosing more and more younger patients. In fact, our own data suggests that most GBMs are glioblastomas diagnosed in Pakistan are now in their 50s. We obviously have more male patients than female patients, and it's not only because of the disease pathology, but also because of the health-seeking behavior in low-income countries where more male patients come to our hospitals for advanced treatment. And for some reason, female patients don't come to a hospital, whether they, and it's speculative, the reason for it. It's around 50% of all malignant primary CNS tumors. We know that the most common CNS tumors are brain mets. Of all the of all the primary brain tumors, glioblastomas account for more than half of them. Despite more than $1 trillion in research, the median survival is still 14 to 20 months. It's a little bit more for the secondary glioblastomas, but for primary or IDH mutant type, but for IDH wild type or glioblastomas, the median survival is still 14 to 20 months. And we talk about the factors which prolong survival. The 5-year survival is still less than 10%. These are the risk factors, but majority of these cases are sporadic. Radiation exposure, as we've seen some patients who've been treated with tinea capitis long time ago, or patients who've been treated with meningiomas many years ago. Recently, we diagnosed a patient who's had a medulloblastoma treated. It was actually my patient who I operated upon for the medulloblastoma 15 years ago. The primary disease has not recurred, but he's now developed glioblastoma. There is a association with radiation exposure. There are some genetic risk factors such as Leishman syndromes and etc., but it's mostly sporadic. Clinical presentation is well, every patient diagnosed as a brain tumor will tell you that he's had headache. But of course, they don't present primarily as headaches. In our series, in patients who are focal neurological fits, usually hemiplegic, almost half of them have had seizure at diagnosis. And some of the very intelligent patients, or those are better educated, will come with more focal deficits. So some patients will tell you that they can't see on the right side, and you will find that they have occipital GBM, or they have a sense of abnormal smell, and you'll find that they have a temporal GBM, or visual field defects and a temporal GBM, glioblastoma. But most patients will have very glaring, very prominent personal deficits, such as personality changes, decreased cognition. Sometimes they also present with raised ICPs, and they might present with hemorrhage, or they'll end up in the ER with hemorrhage or signs of raised ICP, and sometimes you have to debulk them in emergency. Those obviously don't have the best outcomes. Anti-seizure medications we unfortunately prescribe to every patient, although there's now evidence that unless the patient has had seizure, if you prescribe prophylactic anti-seizure medication, their outcome are slightly worse than those patients who are not on anti-seizure medication. So in my personal practice, unless they've had a seizure, I don't prescribe them anti-epileptics before or after the operation. The physical examination will tell you two things. One is the Karnofsky performance score, and we'll talk about that later. And this is extremely important to determine the treatment for these patients. In fact, a lot of treatment algorithms more than 70% to be able to qualify for more aggressive care. The other thing is the neurological examination, which I find extremely important because a lot of times your surgical planning will depend on your examination. For example, if a patient has a glioblastoma in the prefrontal cortex or right anterior to the central sulcus, and you are considering whether you should do an awake craniotomy or do it under GA, if the patient has neurological deficits, hemiparesis or limb weakness, arm weakness, leg weakness, speech, and they get better on steroids. Um, in my mind, I'm thinking that, well, he has edema, which is pushing on the white matter tracks, and the white matter tracks are not directly involved. If the deficits are irreversible, in my mind, before I get an MRI or DTI, I feel that this patient has had a white matter tract involvement. So at best, I will not be able to do a complete resection. I will only be able to do debulking or an 80% debulking maybe. But if their patient has deficits which recover on steroids, to me it's important because then I can think of doing a complete resection. So this is the Karnofsky performance score. This is very, very important because if a patient has less than 70% score, despite steroid, um, th- then these patients are poor candidates for radiation therapy, for example, or for, in case of recurrences, for reoperations. The other is performance score that is increasingly oncology group performance score. And this, so if a patient has more than 2 score on ECOG, then of course these are poor candidates for radiation therapy, or in case of recurrences, a reoperation. So for every patient that we plan to treat, we do a KPS. Some centers do an ECOG. We follow the KPS. The MRI findings, well, typical findings are a GBM will look like a large lesion, usually involving the white matter tracts. They have very classical locations. For example, you will very, very rarely find a cerebellar GBM. It's also uncommon to have truly occipital GBMs. They're mostly in the frontal lobe, near the central sulcus, premotor cortex, temporal lobe, palate-occipital lobe, or deep inside into the corpus callosum, or deep white matter tracts, such as the internal capsule. Typical findings are a ring enhancement and a central necrosis, and a lot of edema on T2 flare images. Plus, they will follow the white matter tracks and will cross the midline according to with the matter tracks. So whether it's a corpus callosum, a posterior tracks, these tumors will you find that crossing the midline. Sometimes they're multifocal, which obviously have a worse prognosis. And the usual differentials are between lymphomas, brain abscesses, and metastases. But typically, the diagnosis of an intraaxial high-grade lesion is straightforward on MRI scans. And the question is not whether it's a lymphoma or abscess or metastasis. The question is whether it's a glioblastoma, whether it's an astrocytoma grade 4 or it's an astrocytoma grade 3. And usually the question between these three diagnoses, for which you will, of course, need some specimen, because as I said, the new WHO classification will not allow you to make a diagnosis on MRI alone or without molecular studies. These are the typical MRI findings on T1 post-contrast, T2 flare, and diffusion-weighted images. So for T1 contrast, you'll find that these have irregular, thick, often heterogeneous ring enhancement around a central large necrotic non-enhancing core, which is iso-intense on T1. This is the classic glioblastoma appearance. On T2 flare, you'll see a lot of surrounding hyperintense signal reflecting a mix of vasogenic and edema, as well as non-enhancing infiltrative tumor. So you cannot differentiate reliably whether what part of it is edema or what part of it is non-enhancing tumor. And so a lot of times, if you're going for a supra-radical resection for the glioblastoma, you will include, by definition, you will include the T2 flare hyperintensities along with the contrast enhancing part of the tumor. So you will not only remove the contrast enhancing part, but also the T2 flare hyperintensity. It's not always possible, but sometimes in temporal lesions, sometimes in frontal lesions, it lends itself to this sort of a surgery, which of course adds or gives advantage to the patient in terms of the extent of the estimated survival. And then we'll talk about the relationship between extent of resection and the probability of survival. On DWI, for glioblastomas is not immensely helpful, but what it can differentiate is between an abscess or in cases of uh, transcutaneous lymphomas. So similarly, and on susceptible vasculature, it sometimes helps you in telling you what to expect during the operation. Sometimes we do an MR spectroscopy, especially if it's a small lesion. There's no central necrosis. We have a question about whether it's a tuberculoma, TB, although we see that less often, but for those reasons, we get an MR spectroscopy and an MR spectroscopy. So the primary reason for getting spectroscopy is not to diagnose a glioblastoma, but to differentiate between whether it's a glioblastoma, tuberculoma, or an abscess, or an old abscess. And for glioblastomas, you will find the typical choline peaks and a high choline creatine ratio plus a small lactate peak and very small NAA peaks. And these are typical findings for malignant tumors with high cell turnover and high necrosis. MR perfusion we don't usually do, but we do it when there's a question whether, when you've treated a glioblastoma and 4 months later, there is on an MRI, you find this as part of the tumor and or a pseudoprogression. Pseudoprogression, as some of you will know, the consultants here obviously, that glioblastomas which have been treated with chemotherapy and radiation therapy, especially after a few months after the end of radiation, will show some growth in the tumor, which enhances on contrast, but basically hypervascularity as a reaction to the radiation. It's not however, it is a recurrence. You can do two things. You can either repeat the MRI in 3 months, pseudoprogression will regress in 3 months, a recurrence will grow further in 3 months. But then you waste 3 months of your time, which you could have used for treatment. The other thing you can do is get an MR perfusion scan. So the perfusion scan, in case of pseudoprogression, will show hypervascularity as we show here. So that's the medial part of the tumor. These are one of my hypervascularity here, which is suggestive of this being pseudoprogression and not recurrence. DTI. So my reason for getting DTI is when I'm deciding whether I want to do this surgery as an a case, or I'm happy to do this. White matter a neurosurgeon who does a lot of brain tumors, especially low grade gliomas, but also high grade gliomas, does not rely on DTI because it's observer dependent, it's technology dependent, it's not 100% sensitive. But to me, sometimes it's helpful because um, on the other hand, lots lots of neurosurgeons I know will swear by a DTI. So for me, it's helpful because the pyramidal tract, and this is the pyramidal tract. So if I can see, so that's the pyramidal tract. So if I can see that the tumor is clearly away from the motor tract and non-dominant side, no speech involvement. So I'm happy to do this as in general anesthesia and not do awake. Obviously, I in operative, I can't monitor white matter tracks. I can't stimulate white matter pathways. So that's my limitation. So, but for me, broadly speaking, working in a low middle income country, this is enough easier. So that's a tumor here, and you can see that how it's just pushing the white matter tracks and not involving them. In fact, we did a study on some of our cases. When we looked at the pattern of involvement of different tumors on DTI, and for the few, maybe for, uh, for 100 cases, I did affected and the found that for glioblastomas, or most of them would infiltrate the white matter tracts and not displace them. Other low-grade tumors will displace the white matter tracts, but glioblastomas will more commonly infiltrate them or disrupt them. So unless you have white matter mapping technology available in your operating room, if you really have to go by DTI, and if there is an impression on DTI that there is infiltration of the white matter tracts, then at best you can debug the tumor. You can't excise it completely, otherwise you risk giving patients permanent deficits. We don't use a lot of fMRI and PET scanning anymore, but fMRI sometimes helps in telling you the motor speech area and the motor cortex. We are only able to reliably do the hand movements on fMRI. So I don't use it a lot, honestly. But now, especially since we are doing more awake cases, the use of fMRI has decreased. The standard of care for GBMs is, of course, surgery. And we will talk about surgery in more detail. And after surgery, if the patient has a good age and a good performance score, so an ECOG score of less than or equal to 2 or a KPS score of more than or equal to 70, these patients undergo concurrent chemoradiation therapy. And concurrent chemoradiation therapy involves giving first-line temozolomide and radiation therapy, 60 gray fractionated, only tumor and the tumor bed, and some surrounding tissue, and there's a separate planning methodology for that. And then following these patients with serial MRI scans and adjuvant temozolomide. And in case of recurrence, um, there's now ample data to support second-line chemotherapy, sometimes even second-line uh, localized radiation therapy, but and also sometimes second surgery for second debulking, and even third for debulking, if there's a need. The again the reason for that will be if the recurrence is susceptible and the patient is in a good operation, third operation, and there's ample data to suggest that they improve overall survival. So both progression-free survival and overall survival. And age, however, is no longer a limitation now. So if there's a good performance score, the age is not a limiting factor for any treatment. Excuse me. The goals of surgery are, of course, first is to diagnosis. Now, with there's no way to diagnose a glioblastoma unless you do a biopsy. And here I must mention, you will sometimes come across these patients with diffuse multifocal large tumors, elderly patients, and poor performance. Working in low-income countries, sometimes these patients have delayed presentations, come from far-flung areas, and by the time they reach you, they're in a stage where maybe it's best for the patient not to do anything at all. But those patients who are in performance score, young patients, then of course the treatment will only start with the diagnosis, and that's one goal of surgery. Whenever possible, you do a maximum safe resection, and there's plenty of data to suggest that the extent of resection is uh, directly correlates with the progression-free survival and overall survival. And any extent of resection, more than 80%, significantly improves survival. A gross total resection, and so you can see here, these are months of survival and the extent of resection. So gross total resection will give you better survival benefit and a super and even better overall survival. As a policy, as a rule, every glioblastoma patient where we have attempted maximal safe resection or the gross total resection, we get an MRI within 24 hours. I get an MRI within 12 hours. Right? Um, uh, that is the basis for any further treatment. Uh, Unless, of course, you're just doing a borehole biopsy, then there's no point. But any resection will require a documentation after the debulking. Uh, so this tumor, for example, left frontal lobe involving the premotor cortex, going down into the internal capsule. My approach will be, and you can see it's probably also starting to cross the line, but maybe it's just on one side of the box. My approach will be to get a DTI, um, get a navigation, maybe do an craniotomy, try for complete resection. uh, No, if it's suitable, resectable, and then take it from there. For all my brain tumors, unless it's a temporal meningioma or temporal lobe lesion, I do a navigation for all these cases. Um, and I plan my craniotomy according to navigations. I usually prefer a linear incision always because they heal better. And if flaps sometimes have problems, and so in some patients they may delay your radiation therapy because of poor healing. Linear incisions heal better, so whenever possible, I use a linear incision, a small craniotomy. For intraaxial tumors, you can dissect a large tumor with a small craniotomy. Hu Dufau, again, hates small craniotomies. He will also always do a big craniotomy. He doesn't use navigation. He doesn't use DTI. He does all of these cases awake. And we'll do a big craniotomy, map the tumor, map the brain, and then do the dissection. Most surgeons I know do it differently. So this, for example, this right frontal GBM, it's a small GBM. It possibly can be confused with the brain abscess or a tuberculoma or a brain met. Um, I did a frozen section, turned out to be a glioblastoma. So I did a supramarginal resection, so a right frontal lobectomy to improve survival. Of course, for cases like these, you don't need navigation. For cases like this, you also don't need DTI. I use navigation as a practice, but of course, these cases can be done without navigation or DTI, and you can have the same outcome as this case. So that's another patient. This is one actually this, oh yeah, this is also my patient. This is a left temporal lobe lesion. You can see here. These are navigation images, so not great. Um, we've saved some money on the contrast here, but that's a temporal lobe lesion. So we did a DTI to make sure that the visual pathways were separate. And when it was clear, we did temporal lobectomy. There was it's not a supramarginal dissection. Actually, there's some residual tumor in the medial temporal lobe and some behind. So that's the left side. So that's near the speech area. So this was an awake craniotomy, and but the uncus is removed here. So the medial temporal lobe is gone. This is probably leptomeningeal disease here, and this is a post-op MRI within 24 hours. So for and cases like these, where it's involving the splenium, it's going to the other side, it's involving the ependyma. Of course, and there's probably multifocal disease involving the leptomeninges on the contralateral side. Your goal of surgery will be different. In this case, you can do some debulking to create some space. Dissections up to 20, 30, 40% will not affect the outcome. The other thing is you can just do a biopsy. Some of my colleagues don't do a biopsy, choose to do a debulking, and their argument is that it helps to it tends to help the patient negotiate with the postoperative edema that you can sometimes have with the biopsy, which is a fair argument. I try and do these cases with just a bowel hole biopsy with just minimal tissue, which tends to minimize postoperative edema, and typically doesn't cause problems. When you try to get too much tissue, that causes more edema. Again, cases like these involving both sides, all you can do is just do a biopsy. Sometimes for biopsies, you will need to have navigation. Sometimes for these biopsies, you need to have an intraoperative frozen section to confirm that you've got the right tissue. Most of these cases, the tissue will look different. It's a very soft, grayish necrotic tissue, easily differentiable from the normal brain tissue. A little bit about awake craniotomies. So, awake craniotomies we've been doing now for more than 10 years. We started with a few cases. We were doing in the first couple of years, maybe around 5% of our tumor cases were done awake. Now we do about 30% of our cases for intraaxial tumors are done awake. In my practice, my preference is not to do awake unless it's really necessary. So my own practice, I think I still about 90% of my cases are done under general anesthesia. But for awake mapping, we use an Ogemon stimulator, brain stimulator, and we use it from 2 milliampules to 5 milliampules, not more than that. And we only do cortical stimulation. We don't do white matter stimulation. I mean, we try. I don't think it makes a difference. There are two schools of thought for awake mapping. For example, Mitch Berger from UCSF would do a negative mapping. So he will just map the area around the tumor if there is no deficits, or if you can't produce a focal response, then you can assume that these are safe areas and you just resect that. Hugh Dufau will do a positive map. So he will just do a big craniotomy, map the entire area around the tumor, identify all the vital structures, vital areas, and then whatever is left behind, he will dissect it. So he's more likely to do supramarginal dissections. I do just a negative mapping. So I stimulate parts of the tumor, parts of the brain next to the tumor, and if it's fine, I just go ahead and dissect the tumor. So I don't do a big craniotomy. So that's a difference between positive and negative mapping. Awake craniotomy has limitations, at least in my hands. For example, if there's a tumor in the supplementary motor cortex, we know that if you map this area, the patient will have deficits. We know if you excise this tumor, the patient will have hemiparesis. But we also now know that these patients will recover from their hemiparesis. So in these cases, doing a mapping actually limits your extent of resection. So if I can clearly identify, which you can in most cases, I can clearly identify the central sulcus, the premotor cortex, the motor cortex, then I will just do a DTI to look at the pyramidal tracts. And if I can see that there is no infiltration of the tumor, and I will do this case as in a general anesthesia and just do a dissection anterior to the motor cortex. But if there's infiltration or if there is partial weakness already in those patients, not reversible on steroids, then I will do it awake, and I will end up leaving a little bit of tumor behind near the motor cortex if it's necessary. We've talked about the role of supramarginal resection. So these cases like these, where tumor is very close or on the motor cortex, these are best done awake. Um, and that's the case I was talking about. That's the central sulcus. That's probably the motor cortex, and the tumor is right in front of the motor cortex. There are lots of intraoperative adjuncts available for use. Um, I will almost always use a microscope. We have an exoscope. We've had an exoscope for the last 10 years. I personally find it not very useful. I've used it for a few cases. I don't think if you have a microscope, then an exoscope is unnecessary in my opinion, but that's just my opinion. Kusa, I keep handy. It costs us a lot of money to get the Kusa for these patients. It makes the surgery more costly. So I will use a Kusa only if there is a firm tumor that I have difficulty separating from a normal brain, or if the great brain tumor interface is not clear. Otherwise, if it's soft tumor, suckable tumor, even if it's vascular, I would just do it with suction and bipolar and pen feed dissector and not use the CUSA. We don't use 5-ALA, it's too expensive, although our microscopes have the features to use it. So 5-ALA, but there's enough data to suggest that it improves the extent of resection. We don't use it, so I have no experience with it. We've tried using fluorescein. It does work. It makes the tumor glow green. It's useful when there is a poor gray brain tumor interface, if the tumor looks very like the normal brain. But for most glioblastomas, that's not the case. And with a good navigation, with good or if you're doing awake, then fluorescein is it's good to have, but it will not change your management immensely. But it's something it's good to have in the or when you're planning such cases. Raman spectroscopy, there's a lot of interest in this. So it's kind of where they're able to differentiate between tumor types according to how it displaces light. And now they can do Raman spectroscopy in the OR within minutes. So it's like an intra frozen section. So it guides you whether you are excising the tumor or you're near the brain or it's the edema or not the tumor part, and helps you decide when to stop or when to keep going. We don't have it. It's still experimental. It's not openly available to use. We have an intraop MRI, but it's a very low, a small magnet, very low yield. We've used it in maybe a few dozen cases. Um, it's At the moment, our intraop MRI can only be used for experimental basis. It doesn't help us decide treatment. It doesn't help the patient in the sense that it doesn't improve our extent of resection at all. But in centers with better intraop MRI scans, yes, it does have a role to improve your extent of resection. I completely agree with that. I use intraop ultrasound a lot. Um, Especially with multicystic lesions, where there are questions about whether you've opened, once you've inside a tumor, you do an internal debulking. You question yourself whether all the cysts have been opened, or there's still cyst involved, and by that time the brain has shifted, so the navigation is not helpful at all. So you can use intraop ultrasound, or you can use endoscope if whatever you feel appropriate. I use intraop ultrasound, not just for glioblastomas, but also for spinal cord tumors a lot. And I do them pre-op baseline, and then intra-op, and then post-op, just to make sure that I've taken all the tumors out. And I find this a very helpful technology. It's low cost. It's easily available. You don't need another person to do it for you. and it can be repeated many times. And the best thing is that it doesn't waste time at all, and it's not affected by the brain shifting. And I use it also for low grade gliomas, and I found that it's also very helpful for low grade gliomas. So that's our intraop MRI scan. It's a portable MRI. As I said, I didn't find it useful at all, but better than MRI scanners. 1.5 Tesla will, of course, they improve extent of resection by all means. Um, Surgical complications are the same complications you expect. It can post-op hemorrhage, post-op seizures, etc., etc. But the thing that you need to worry about sometimes is after biopsies or after, um, uh, especially after incomplete resections, these tumors can bleed post-op. Because the best way to prevent post-operative bleeding is to excise the entire tumor. Because the normal brain is not as vascular as the glioblastoma. So if you leave tumor behind with the abnormal vasculature, they will. There's a chance of bleeding. There's a chance of postoperative edema, something that people have called the angry glioma syndrome. Um, it's a very cheesy term. I don't use it, but it's described by a lot of surgeons, and it's in the literature. So those are the two things you need to worry about. So whenever you feel that your biopsy or your debulking will lead to an angry glioma syndrome of immense postoperative edema, which can sometimes be fatal for the patient. The only way to go about it is to debulk more, make sure you have complete hemostasis, make sure you don't leave abnormal vasculature behind, which can bleed later on. These are classical um, histological findings at necrosis, microvascular proliferation. uh, Lots of molecular pathological markers that need to be now done routinely. We do IDH, we do TERT-P, we don't do EGFR. We do P53 ATRX, 1P19Q. And the classic glioblastoma will be IDH wild type, retained ATRX, P53 mutant, and a Ki index of more than 60%. Um, MGMT status is, we routinely do this. It has a very good prognostic indication in terms of how these patients will respond to temozolomide chemotherapy. And so if the MGMT methylation status, if the patient has unmethylated MGMT, then so MGMT, what it does is that it's a DNA repair in gene which um, so temozolomide will act by damaging the DNA. It's an alkylating agent, so it will damage the DNA in the cancer cells. And if the patients have MGMT, then they will repair the DNA. If the MGMT is methylated, then that repair mechanism is lost. So the temozolomide will be more effective. And you can see here that the methylation status as a response to chemotherapy, that when these patients have MGMT methylation positive, then their survival is much longer than about 2 year, 3 year, 4 year, and 5 year survival as compared to patients where the MGMT is unmethylated. So this is one of my patients with a methylated MGMT where we could only do a biopsy of the lesion, but look at the post-op CCRT response. The tumor is almost gone. And quite a few of our patients with this disease will respond very well to CCRT if the methylation status is favorable. And despite just debulking, these patients will survive for years just on adjuvant chemotherapy. Well, emerging biomarkers include liquid biopsies. We're doing a lot of that. Then there's circulating tumor cells, TEPs, circulating tumor DNA, and microRNA. So we're also doing a lot of basic science research on microRNAs and their role in GBMs. At the moment, it's all experimental in the sense that there are some microRNAs which have shown up to 80% sensitivity in diagnosing, but it's still not good enough to replace an MRI scan for follow-ups and for surveillance. But there is definitely potential in this area as a research for research. So this is the Stoop protocol that every center in the world will follow now. That these patients will, after surgery, will receive concomitant chemotherapy and radiation therapy. Temozolomide is given at 75 milligram per meter square per day per oral dose during radiation therapy, and the dose is changed after radiation therapy. Radiation therapy is, of course, planned according to where the tumor is and different things. Um, and then these patients are followed up with 3 monthly MRI scans to make sure to look at the response and if there is change in response and then do differently. And there are other things that we'll talk about. So there are novel therapies. There is a lot of interest on tumor treating fields. We don't use it. We don't have it in Pakistan. But it's useful for the small recurrences, deep-seated tumors, previously diagnosed, of course. Um, and my friends tell me that, and there's literature to support that the results are fantastic. Bevacizumab, which is an anti-VEGF. It's there's definitely some role for recurrent tumors with a lot of hypervascularity, a lot of edema. It has been shown to improve progression-free survival, to improve symptoms. However, it has not been shown to affect overall survival. So patients become better symptomatic in terms of symptoms. The MRI looks better, but it doesn't affect the overall survival, and it's also expensive. Carmustine, well, Dr. Javeed will talk about Carmustine. He's using this in Malaysia now. Optune is a new technology where this cap is patients are required to wear these caps for the entire day for weeks, and very, very expensive, costs thousands of dollars. Not great outcomes. I don't see it becoming popular. Immunotherapy definitely has a role. And it's something that we are very excited about. Let's see what the future holds. And then viral carriers and gamma knife. So that's the VEGF antibody. We use it, bevacizumab. It's available. As I said, it's expensive. It does affect, if you see here, recurrent baseline, recurrent GBM, and response to anti-VEGF. Same here. It does improve the Ebola scan. It does improve patients' symptoms, but it doesn't improve the overall survival. That's laser interstitial thermal therapy. We talked about this. So the ideal lesions are patients with recurrent tumors, potentially high risk for another craniotomy, with deep-seated lesions, thalamus, hypothalamus, brainstem as suitable targets. Photodynamic therapy is also emerging technology. We haven't used it, but this is something that we're eagerly looking, following to see if there's a role for it in future. We follow up these patients with MRI brain with contrast, um, uh, and we use the RANO criteria to report these MRI scans. That's accepted criteria. These are the consensus guidelines for management of adult high-grade gliomas that we published last year, and this was circulated widely in the entire country. And these are consensus guidelines that we developed with the Pakistan Brain Tumor Consortium, which was started at Afghan Hospital in my department and involved almost every major department of Pakistan. This is more than 100 neurosurgeons from across the country, more than 40 centers across Pakistan. And these are the guidelines that we all came up with. So if there's MRI suggestive of high-grade glioma, early referral to radiation oncologist. Um, if the KPS is more than 70, then decide if it's elegant, non-elegant, decide if you want to do an awake craniotomy, maximum safe resection or complete resection, or if it's elegant, impossible to dissect, then just do a biopsy, but the treatment starts with the histopathology. If the patient has a poor KPS, then you just do a palliative care. Once you have histology, then the case is discussed in the neuro-oncology tumor board. We as a policy discuss every tumor patient, whether it's newly diagnosed tumor or follow-up or surveillance. Every tumor patient is discussed in a tumor board. I can't emphasize the importance of tumor boards enough. No brain tumor patient should be managed without being discussed in a tumor board. It has helped us immensely in becoming better clinicians, better surgeons, better researchers. Most of our research is now done with our colleagues in medical oncology and radiation oncology. We also hold tumor boards with our national collaborators across Pakistan, with centers in Peshawar and Lahore and Quetta. So pediatric tumor board we do with all of these centers separately. Adult tumor board, we do a national tumor board once every month. Our own tumor boards we do every week for adult brain tumors. We do every week for pediatric brain tumors. We do once every 2 weeks for pituitary adenomas, and then we do one for spine. So we're holding maybe around 20 tumor boards every month. And then we do a joint tumor board with Hospital for Sick Kids Toronto every month, where we discuss our complex pediatric cases. So I can't emphasize enough the importance of tumor boards, and I would invite the Afghan Society to join us in in our tumor board and bring their cases and see how we manage ours. I'm sure we'll both learn from each other. And every decision is based on the consensus from the tumor board. And if there's a consensus of resection, so if I do a post-op MRI within 24 hours, present to the tumor board, and my oncologist says, okay, you need to take some more tumor out, I feel that I can do it, then I take the patient back to the OR and do it. But every decision is through the tumor board. These are my steps of surgery. I have 4 minutes and then I'll give the podium back to Dr. Javeed. But navigation I use almost always, DTI mostly, awake mapping sometimes. Intra-op ultrasound, it's available in the OR if I need it. I don't have to book it. It's right there. I never use an intra-op MRI. I sometimes use a CUSA, depending on where the tumor is and what I plan to do with it. My preferable incision is linear. I start with an internal debulking. I use very little bipolar. Try and find the plane between the tumor and the brain using a pen feed dissector. I do most of my dissection with the pen feed. Only if when the bleeding will happen. Most of it will stop as you dissect the tumor out. But if it's affecting your vision or if there's a lot of edema, then of course I will sometimes use a bipolar, but only minimally. Not carpet bipolaring, but it's just find the vessel that's bleeding and control it. Most of these tumors, bleeding can be stopped with just cotton balls and irrigation. And I continue with my pen field dissection. But otherwise, I do use a balanced bipolar to control it. I do a post-op MRI within 12 hours of surgery. We've published the results that if you publish it, you do an MRI later, the post-op changes tend to be confused with the residual tumor. So do it as early as possible, and if you have to delay it, just do not delay it beyond 72 hours. If the 72 hours have passed after surgery and you haven't done a post-op MRI, then it's perhaps best to just wait for 3 months and then do it. Otherwise, preferably do it within 24 hours. I discuss all my cases in the MDT. Thank you. And this is my email address.
Thank you, Shahzad. That was excellent talk, actually. It's a beautiful talk. And we have a lot of audience all around. We have a lot from Malaysia, from Afghanistan, from Pakistan. Great talk. What we do is basically a little bit of I open the room for discussions to discuss these things, because the GBM is after WHO CNS 5 to 2021. Basically, the paradigm totally shift. It's become totally different entity. And some of them, we discussed that basically the new shift, what was the change on that. The second one is after the discussion is basically we'll have a little bit for collaboration, what we can do with Afghanistan sites. So I will give one questions. Basically, I'll put one question, then we'll ask the the audience to keep their question just like for 5 minutes. So basically on this 2021 CNS, when they change, basically 21 entity has been changed, including there's no more any anaplastic grade 3, they take it away. So as you said, IDH mutations, IDH with some markers plus wild type. Does it change your practice, like how you treat before 2021 and after 2021 in terms of GBM? Because it's become much more molecular, not anymore histological. Shahzad.
Yes, and it's interesting you mentioned it. We were in Manila just a few days ago, and I
Yeah.
had the same discussion with Hugh Dufau, the prominent professor from Montpellier, France, and he said the same thing. So the classification has changed, but as surgeons, our approach is the same. So if so for us, the goal is the question that we have to ask is, does this patient um, need surgery? Yes or no? If the patient needs surgery, can I remove the tumor? Yes or no? If I can remove the tumor completely, I will do it. And whether it's a grade 3 or grade 4, if it's IDH mutant or IDH wild type, whether it's a grade 2 or grade 1, we know that the extent of resection directly affects survival, both overall survival, progression-free survival. It affects the response to chemotherapy, response to radiation therapy. So I will do it. If I cannot remove the tumor completely, then my next plan will be to resect as much as possible. And we know that this also directly affects the overall survival and the response to chemo and radiation therapy, regardless of what the molecular this thing will. The what it has the new classification probably has affected is um, our ability to uh, uh, to study these tumor better. So now we are able to classify these tumors differently. So we are able to analyze these tumors differently, and we are able to come up with the better prognostic indicators for these different types of tumors. But from clinicians, I don't think it has changed anything for us at all.
Yeah, in relation to just thank you. Yeah, thank you, Shahzad. Because we do have a very huge, experience here in Malaysia. Then later I'll come. So I'll open any other one. If you have a basically question, please on your cameras. Please, Dr. Shahzad will see you in a future meeting, any conference, and ask your question directly in regards to the GBM. Raise your hand. I think we'll pick you up. Or you can write down your question on the chat box. We do have Dr. Rishad and Mustafa. I think they can. Any questions? Shahzad, I just want to ask if there's no more questions. I just want to keep on the discussions. You said the role of fluorescence here in Malaysia, we're using 5-ALA, leucoleolanic acids and fluorescence. Do you guys using in Aga Khan the 5-ALA or fluorescence?
No, so we don't use 5-ALA, and the reason is it's expensive.
Yeah.
But we use fluorescein. I've personally used it quite a few times. It does help, and there are many studies which show both 5-ALA, especially 5-ALA, but also fluorescein, to improve the extent of resection for high-grade gliomas, especially, not so much for low-grade. My so my uh, uh, the real difference that these agents will make are for tumors where you can't differentiate the tumor from the normal brain on direct microscopy, on the white light, on the microscopic light.
Yeah.
The tumor is easily differentiable from the normal brain, then these will have no use in my mind. My guide for extent of resection is not just what is visible on naked eye. My guide will be the navigation, their DTI, or when I'm doing an awake craniotomy. So even if I don't see any tumor there, but on DTI, I know that there's room where I can dissect a little bit more, even if it's normal brain. Or from an awake craniotomy, I know that I can, so example, it's a right frontal lobe. I've dissected a tumor. So I will rather go for a supramarginal resection. In cases where you want to do an internal debulking and you're not sure whether you can differentiate the tumor from the normal brain, then these agents will make a difference. So it's something that it's good to have. It's not essential in my mind.
Yeah. I'm not sure, like, I have one or two slides. I mean, I'm not sure how many audience have seen how the 5-hala will work. I have one or two slides. If you want, I'll just show to them basically
If you look
how
at the
they
data, the data clearly
Yeah.
suggests
Yeah.
that a 5-ALA improves extent of resection.
Yeah, definitely. But basically, what was our experience here in Malaysia? He said MRI within 72 hours. I think it's almost impossible for us to get within 72 hours the MRI post-op for large centers. And that's basically the game changer. If you cannot get it, you don't know like how it is. If you're getting after 3 months, basically the tumor was double of what we have done and everything. So that's really the catchy point. You have to be very careful.
So my practice is I get the MRI. So MRI machine here in Karachi, we have 2 MRI scanners in my hospital. They're very busy, but they become less busy after 8 p.m. or 9 p.m. So for all my brain tumor patients, they get an MRI in the middle of the night. That does mean that the patient loses the sleep. They have to wake up for the MRI. But all these patients I operate in the morning get an MRI the same night. So in the morning when I come back to talk to the patient, I have the MRI report with me to discuss with them that, hey, listen, your surgery went well. We've done the post-op MRI. There's no tumor, or there's a little bit of tumor, and we'll just have to, wait for the biopsy report, and we'll take it further.
Sure. Any other questions?
Also, for not the same type. So for pediatric tumors, especially medulloblastomas, I don't extubate my patients. So after surgery, they remain intubated. They go to the ICU. They first get a post-op MRI, and only then they get an extubation.
I see.
That's my practice for all pediatric tumors.
All right. Okay. Any question from Afghanistan? Anyone?
I think, we have Dr. Jomi. Maybe we can give him the mic.
Sure.
Then I will ask my own question. Okay.
All right. Okay, Jomi, sab. Mehrabani.
Hello, and how are you? Thank you for your presentations. I have one question that in the glioblastoma, when the astrocyte grew up, how they grew up in the brain, and how can astrocyte grow up and replaced by the normal brain tissue? Meanwhile, other tumors of the brain, when they grow up, they have their own mass, and we have brain also too. In glioblastoma, the normal brain replaced by glioblastoma. How this fact happen in the brain? And do astrocytes normally proliferate? And how does this relate to the development of glioblastoma? And how does glioblastoma replace normal brain tissue? And how does glioblastoma infiltrate and replace normal brain tissue? Thank you.
Yeah, so thank you very much for that question. First, it's a basic science question, if I understand correctly. And like all cancers, glioblastomas come from the astrocytes, and they tend to grow with the white matter tracts. We have very early reports written beautifully by Professor Ghazi Yashagil, who has, despite not having a great educational background in basic sciences, he was able to determine, based on his experience with thousands of gliomas, on the pattern of growth of these tumors, and with his knowledge of microneurosurgery and white matter tracts, he was able to see a pattern of growth of these tumors on the pattern of white matter tracts, whether it's the frontal, temporal, and I must encourage you to read his text on how he has described the pattern of growth for these tumors. It's really a piece of art for somebody to write them in the late 70s, early 80s, before all of this technology and DTI and MRI scans. Is just fantastic to read those. We know that these are abnormal growths like all cancers, and they have a preferential growth that we see for different types of cancer, and that's why these tumors don't metastasize; they only grow locally grow. They replace brain tissues by mitosis, by abnormal unrestricted growth, and the growth is so fast that it exceeds the ability of the tumor to get new vascularization, although neovascularization is part of the pathophysiology. So that's why that leads to the central necrosis at times, most of the times. So that's the tumor growing faster than it can supply, get its own blood vessels. And then that leads to the edema and all. It doesn't always involve brain cells. Sometimes it only displaces them. At least earlier on in the disease, it starts with displacing tissue before it infiltrates it. And that's why on the basis of MRI scan, sometimes you can't say if the disease is resectable or not. And that's where it helps to use DTI and awake mapping to find out whether some of the tracts are just displaced or infiltrated. So even despite all our knowledge, we're not able to tell that for every tumor, the pattern of growth will be the same. Similarly, it's and maybe there's more to it that we haven't understood, that we will understand with time. Similarly, if it involves the ependyma, the CSF pathways, there is a risk for drop mets. So if for like any other glial tumors, if there is involvement of the ventricles, the ependyma, the CSF pathways, you have to evaluate them for the entire neuroaxis for drop mets anywhere in the spine. So if there's leptomeningeal involvement, that's one thing that you can you have to expect, and if there are drop mets, then you have to include that in your radiation therapy.
Thank
I
you.
hope that answers your question.
Thank you, sir. Thank you.
Thank you. Yeah, that was purely basic stuff. Yeah. Yeah. Go ahead.
I think so the whole presentation was totally amazing, and there were lots of things to learn, especially for the residents like us. And the one point which Professor Shahzad really emphasized on that, and there was also a big lesson for us regarding the tumor board meetings. I think we need to find a mechanism for that for Afghanistan so that we can do some national meetings. And then later on, we can collaborate and we can work with the Pakistan Neurosurgical Society as well, so that we can discuss our own cases. This is the first thing which was really eye-catching, which is very important, and so that I started to re-mention it again here. And the question is for me, so I know that Afghan is running different projects. We are also part of some of those projects. I think there's one Pakistan brain tumor epidemiology study. We are also working on that. We are also part of that. And there's another project with the German Cancer Research, I think somehow like that, regarding the pediatric neuro-oncology. Anyhow, there are lots of researches going on around the world, and despite of all the advances in surgery and radiotherapy and chemotherapy, so the overall prognosis of GBM is still very poor. The way the world is expecting to have a good prognosis, despite of all the money is going on and research are going on, so there is no favorable outcome for the GBM. So the question is what will be the next major improvement in the treatment with the GBM? Maybe it's coming from the genetic or molecular research level thing. Something maybe need to be changed in that level so that we can have a good conclusion after treatment. Or something need to be changed in immunotherapy, or whether there should be any breakthrough in the artificial intelligence that might change the outcome of the GBM. What do you think, Professor, that in the near future or far future, which of these mechanisms of these pathways will cause a major improvement in the outcome of the GBM?
Yeah. Thank you, Rashad. That's a very very good question. And in my opinion, and I may be wrong. So there are different areas of GBM research. The first thing is the diagnosis. We used to call every high-grade neoplasm a GBM in the past. Even until 2021, we have redefined our definition for the GBM, right? So that tells you that we still don't understand if glioblastoma is one disease or whether it's a spectrum of diseases. So we're still understanding what the disease is. So that's one thing. A lot of research is going on. I agree. It's more than $1 trillion of research in the last 10 years, and no great survival benefit. So a lot of this research is on the diagnosis, on radiology, on molecular pathology, on microRNA, on liquid biopsies. A lot of this research is on surgery, on chemotherapy, radiation therapy. In my opinion, we've reached the end of our technical achievements in terms of surgery. We can't do any better surgery for GBMs except for whatever we are doing right now. It's not going to improve the outcome anymore. In terms of diagnosis, radiology, molecular pathology, that doesn't improve outcomes. Radiation therapy, I think we've reached the end where at least for the next 10 years, there's nothing on the horizon. As you see for the rest of the cancers of the body, the radiation therapy is not changing. There are no new, to me, the only thing that can be a future game changer, as we have seen in lung cancers, for example, or for some other cancers like blood cancers. Immunotherapy may have a future role that can completely be a game changer. And I hope for a day when for GBMs, we have enough radiology technology that we diagnose it on radiology, or we do a liquid biopsy. We just get a sample from the patient's plasma. We diagnose that this is glioblastoma, IDH mutant, or the ATRX negative, positive, whatever. And just based on the serum and the radiology, we are able to start immunotherapy that will completely dissolve the tumor. There should be no need for surgery because, of course, we've seen this for the last 20 years. Surgery is not making a difference. We can improve the extent of resection. We can improve outcomes by 3 months, 6 months, but that's it. That's not a lot. So I think like lung cancers, for certain lung cancers at least, I think immunotherapy is something that will develop. There's now a lot of research on using oncogenes and viruses to directly attack the tumor, customization of chemotherapy for each GBMs. And there's also an interest in what is it? It's well, it's about, but immunotherapy and nanotechnology to deliver chemotherapy directly across the blood-brain barrier at the tumor bed. So those are the things that will change the outcome, not surgeons, I must admit.
Thank you very much. Thanks.
Excellent. Thank you.
The sad part is, and there's a discussion on it. So there's just been an FDA approval for a drug that reverses IDH mutants, IDH, and it's got an FDA approval. It took $3 billion of research to develop that drug. Now that drug is out. It may have a role, it may not have a role, but that drug is costing at least $100,000 per patient per year. Now, even if that drug works, how long will it take for the people from Pakistan and Afghanistan to be able to afford that drug for 1 year of benefit? You see? So my fear is that immunotherapy will come, it will benefit patients, it will get an FDA approval. For the first 5 years, our patients will not be able to benefit it unless they can afford it, unless they're politicians, unless they are smugglers. So we will only afford it when the FDA opens it up and it becomes affordable for low-income countries.
Perfect.
Thank you. So Shahzad, I just want to bring a little bit of this discussion furthermore, because there's a lot of surgeons sitting from Afghanistan and furthermore, I mean, there's two things I want to discuss. I'm coming to surgical complication. So basically GBM is, most of the studies shown that in a best first world and everything, the outcome is basically, if you do total, getting 1.5 year, maybe 2 years. We had 1 or 2 patients, basically. I had one patient actually, he lived for 5 years. And what's happened to that when we take out the bone? And he's got like horn on his head, and the GBM is growing like this. And other day, one surgeon from Afghanistan also called me. He said that one guy is like, also the bone was out. They take out the bone, it's like coming up. This is one of the complications which I tell. I think it's disease is not curable. Instead, if you want to make like help, I think the bone, if you're putting there, I think if you will die peacefully, but it will be, all of his life will be miserable. I'm not sure do you have that experience or not. The second thing is, if a patient's coming in Afghanistan, low resources countries, with the GBM, diagnose the GBM, what's your advice based on your experience? Like, like it's ethical, or it's things that's they'll be operate then without temozolomide or chemo radiotherapy, what with outcome, not operate. What's your strategy if you're being in that kind of situation?
Yeah. To answer your first question first, well, the risk of complications are significant. I agree. I mean, the mortality rates with GBM surgery is less than 1%. Morbidity is around 5 to 10%, but minor complications, major complications you can avoid. For recurrent GBM, if you operate, the risk of stroke is almost 25%. Some series report up to 50%. Small to medium-sized strokes can happen in up to 50% patients when you're operating for a recurrent GBM, because there's so much adhesions. The vessels are abnormal vessels are so undifferentiable from normal vessels. So the stroke risk is high for recurrent GBMs. So one has to be careful. Taking the bone flap off, we've managed a few patients who, in the heat of things, the surgeon took the bone flap off and the GBM started growing. So if you have an intact patient walking around with a herniated brain, that's maybe acceptable. But imagine a comatose patient with a KPS of 40, 30, 20 with a herniated brain, and that patient is not going to die, and the patient is not going to be useful. That life is not useful for the patient or the family. So that becomes quite a painful situation. And you can't put the bone flap back on, you can't resect the tumor, and it can't help the patient in any way. So sometimes that becomes a very painful condition, both for the family and the physician. The patient, of course, will never know. So sometimes the tumor will only grow outwards, but most of the time it will not only grow outward, but will also grow inwards. So we'll have a comatose patient with the herniating brain who just refuses to herniate and die. The second question is about the rationale for the debulking surgery without chemo and radiation therapy. I still think, well, and there's a lot of data that adequate debulking surgery is also proven to improve survival, even without chemo and radiation therapy. It's not ideal, but remember, the diagnosis of GBM is based after the surgery. So unless you operate, you never know you're treating a GBM, really. So even if you do, and in fact, there's previous data which shows that even steroids improve outcomes, improve extent of survival, improve length of survival. So steroids improve survival, surgery improves survival, chemotherapy more, radiation even more. So even if we can't offer chemotherapy and radiation, I still think that as physicians, we can help our patients by debulking the tumor as much as possible, keeping them on steroids and hoping that they find a way to get chemo and radiation therapy. If not, at least you have done whatever was in your hands.
That's right. Yeah, I think that's the best. I think I totally agree with you. I think that's the best we can do, because we face this kind of situation in Afghanistan quite frequent, and the doctors basically they don't know this dilemma: operate, not operate. It's very fast growing tumor. the issues. Basically, I think whatever they can do, they do it, and the rest is basically, I think, let it go. All right. Any other questions?
We get our temozolomide from two means. One way is we import it from the US, which costs a lot. The other way is we smuggle it from India.
Yeah.
And it's cheaper. But
Yeah,
it's
India's very
available.
cheap, yeah, India is cheap actually. Getting generic one is also getting. Malaysia also getting from India because the thing is very expensive.
So we can't get we don't have a relations with India. We can't import it from India, so we have to smuggle it. But it's good for our patients, so we use it.
And thank you, and we will hope to having you in the future as well, Shahzad. Thank you very much.
It's been a pleasure again. Thank you very much. Thank you.